I'm Thomas Baldrick. Our ASH 2015 coverage continues. Joining us now is Dr. Alex Spyropoulos from the North Shore LIJ Health System. Nice to see you again, sir.
Nice to see you.
So you've got a couple of things here. Let's talk about, I know one study that you're very excited about, external validation of a risk assessment model for bleeding risk in medical patients. You're a first in this area on a bleeding risk model. Let's talk about what you've presented here.
Be happy to. I think one of the exciting things about bleeding risk is, number one, that finally we have an evidence-based and evidence-derived algorithm for predicting the bleeding risk in select groups of patients who are hospitalized for an acute medical illness. And now for the first time, we have an external validation study which has been validated in a completely external population from which the model was derived, and found very similar characteristics in the external validation group vis-a-vis the derivation group.
How are you able to go about doing this?
Well, we use the retrospective chart design using ICD-9 and claims analysis, and we use our own North Shore LIJ Health System, and we were able to find over 12,000 patients that met inclusion criteria and didn't meet exclusion criteria. And that's how we really started our analysis.
Magic of technology.
Absolutely.
Okay, so what stands out to you?
But what stands out is that it does appear that the weighted score of 7 is a good cut point to predict those acutely ill medical patients that are at increased risk of bleeding, with or without the advent of anticoagulant prophylaxis. And remember, the improved score included about 11 both clinical as well as laboratory risk factors using various weightings, and that's what's exciting. So for the first time, we don't only have an evidence-based algorithm, but one that's weighted. So those patients, after they hit a score of 7, they have an over twofold increased risk of both overall bleeding, but also major bleeding.
How do you explain the importance of this?
Well, the importance is huge because now all of a sudden we're going to the individualized patient for both VTE as well as bleeding risk assessment. So in theory, once we can further validate the score using, again, a management a cohort or management study, then we would have the individual patient in front of us, we would have a bleed risk calculator, we would have a VTE risk calculator, and individualize both VTE and bleeding risk in this patient, and really assess at the patient level whether that patient would benefit from pharmacologic prophylaxis. We've never had that before.
So obviously you don't sit back and celebrate now. What do you do next to build upon this?
Absolutely. I think the next phase is really a prospective management study embedding the score in a group of patients that really fit the moniker of the hospitalized acutely ill groups, and see what happens once we use that cut point of 7.
Very good. Congratulations on your success. Good news, certainly.
Thank you. Thank you very much.
Okay.